What are the two most important things in cardiac arrest? Chest compressions. What's the other one? Early defibrillation. Chest compressions, early defibrillation. I'm going to blow your minds. I think there's something more important. I think there's one thing that we can do that prevents death from cardiac arrest that's even better than chest compression, even better than early defibrillation. So let's talk about a case. I was working in the ER and I had a senior level resident with me, really competent resident. I struggle with these because I like to play. I like to be the resuscitationist, and I know I need to let my residents stretch your legs. So, call came in, CPR in progress. They roll through the door. They just got ROS. Great. I go in there, kind of standing in the corner, making sure everything's done. They're doing the appropriate things. They're looking at the heart, getting an echo, getting an EKG, getting them up on the monitor, getting them on End-Tidal CO2. The patient's already intubated. So I kind of slide out of the room. My deal is I sit on the counter outside the room because I can't leave altogether, but I want to be there. And so I'm sitting on the counter, watching everything play out. They're calling for meds. They're doing all the right things. And then I jump off the counter. I run into the room. I grab the co-dose epi and I push about a milliliter, a little bit less. And everybody just freaked out and I flushed it in IV. And everybody's like, what are you doing? And just then the blood pressure finished cycling again. And my systolic went from 170 to 60. Went from 170 to 60. And I pushed just a little bump of epi right before that happened to make sure it happened. Let's talk about End-Tidal CO2. I'm going to break this down very easy. I apologize if this is too elementary, but there's three things that play into getting us that End-Tidal CO2 reading. First of all, there's metabolism. We got all these little factories, right, in our peripheral tissue. These things are producing carbon dioxide. Got carbon dioxide all over the body. Metabolism produces the carbon dioxide. I've got this guy that's going to transport that for me. That is my cardiac output. Cardiac output, I've got to have that to get that carbon dioxide from the tissues back to the lungs, which leads us to the third part of this, and that is the lungs and the airways. Those are going to contribute to that End-Tidal CO2 reading. That's it. Metabolism, cardiac output, and my lungs and my airways. Those are the three things that are going to change my End-Tidal CO2 reading. Very quickly, let's look at some waveforms. If you already have the basics down, my apologies. We will run through these quickly. This is your basic End-Tidal CO2 tracing that you want to see. This represents exhalation. This first little part right here where I first start to inflect up, this represents my upper airways, my mouth, my trachea, right? The stuff that doesn't really have any CO2 in it, or maybe has just a little bit. As I have this sharp inflection up, this is representing my tracheobronchial tree, getting down a little bit lower, starting to get more CO2 content. And then finally, as I get to phase 3, this plateau, this is representing my alveoli. This gas has finally kind of reached the detector and it slowly will plateau up and end right here. The peak of this plateau, the highest it gets, that's going to be my reading. That's going to be my number. When I get my number, it's going to be right here. And then as I breathe back in, as I take a breath in, I'm going to rapidly come back to zero. This is what you want your waveform to look like. You have the alpha angle over here. You got the beta angle on this side. Alpha is representing more of exhalation. Beta can show us some stuff about inhalation. But you see, I got two good sharp angles there. Some textbooks say you want these at 90 degrees. They're never at 90 degrees. But I see good sharp points. This is a basic waveform that I can look at. So what's the one thing that you can do? It's kind of a trick. There's one thing you can do more important than chest compressions, more important than early defibrillation. Don't let your patient go into cardiac arrest in the first place. Let's prevent cardiac arrest. And let's, if we never jump on the chest and do chest compressions, I don't have data for this, but in my mind, if the heart does the work rather than me externally doing it, I'm going to have better outcomes. So let's use End-Tidal CO2 to prevent arrest. One of the most fear-inducing scenarios that we think about are a failed intubation that is unrecognized that leads to cardiac arrest. I gave a variation of this lecture back in May, and an article was just published like the week before that was talking about a surgical center that had an esophageal intubation that went unrecognized. And the patient went into cardiac arrest. They ended up having brain damage, ended up dying because of it. And obviously there was a lawsuit. A failed intubation that's unrecognized is unacceptable. And we can use End-Tidal CO2 to determine that. The colorimetric thing, your little purple yellow guy, you have acid in your stomach that can change that color. If you've insufflated the stomach, there may be some carbon dioxide in the stomach that's going to come out and may change that color. What you're looking at is the waveform. If I see a waveform that looks like this, you see how it's kind of dome shaped? I don't have those sharp corners. This is a tube in the goose. This is an esophageal intubation. And you might get color change with this. I don't care about that color change thing. I want my waveform attached when I put the airway in. I'd like to think that most of us would recognize a goose tube initially. Most of us would recognize a tube that oh, nope, that's in the esophagus. Let's pull it. Let's try again. I think this is the one where we get into trouble. Where, okay, I'm in. Let's hook them up to End-Tidal. Great. That's a tracheal waveform. Great. Walk away. What happened here? Tube slipped out. You can have the tip of your ET tube through the vocal cords and your cuff is not through, and you get a good couple of good tracheal waveforms. You get that good color change. You get good breath sounds. You're like, great, we're in. And then it slips out. Now the tip of your tube is in the esophagus. Some people have really good gastric compliance, and your vent may not alarm. Your vent may be getting volumes back from that stomach, and no one realizes that our tube is slipped out until the patient becomes hypoxemic and our pulse ox goes off, unless you have your waveform End-Tidal CO2 and you see that waveform go from the good boxy waveform to the more esophageal pattern. Then the other scenario is this one right here, where I have two really good breaths. My ventilator gave a breath here and I didn't see anything. Something's come disconnected. You should get a vent alarm with this one. You should get a vent alarm with this one, but maybe not necessarily. Maybe not necessarily. So an abrupt change in your waveform usually represents an airway with an issue with the airway. Let's look at this patient. We get an End-Tidal CO2 waveform. The left looks really good, and the right's kind of tapering off. You will see this with some kind of leak in your system, and you may be able to detect it. There may be a cap that's off. You may hear it hissing. Your cuff may be down, and you may hear that coming out. Or you may be leaking air into the pleural space, and you may have had that COPD patient that was overdistended, and we gave that positive pressure, and we popped something, and now they have a pneumothorax that is expanding. So if you see this, find your leak. And then I have this one. Oh, it looks pretty good. I'm sorry, that was a normal one. It's 38. I'm sorry, that's another normal one. It's 30. Sorry, another normal. It's really boxy. It's 20. What's going on here? So End-Tidal CO2 is the poor man's A-line. If I have, remember, it matters about metabolism, it matters about airway and lungs, but it matters about cardiac output. Fluctuations in cardiac output, small fluctuations, it's not as good as detecting. It can detect them briefly, and then everything will normalize. But an abrupt, major change in your cardiac output, you will find out about on your End-Tidal CO2 waveform. This is what I saw in that patient that was post-arrest. I saw this patient's End-Tidal rapidly dropping. If you see this, your patient is peri-arrest. Intervene now. I don't like pushing epinephrine out of the code ampule, right? It's not clean. I'm going to overdose them with epi. I know I will. This is not the time to mix your push dose epi and give 30 to 50 mics. This is the time to go and say, I've got less than a minute of spontaneous circulation. I need to get something in this patient now, immediately. This patient is about to go down. I prefer a real A-line rather than the poor man's A-line, but that takes a little bit of time to put in, get it on the monitor, get this up immediately. My post-arrest patients, I'm always calling for Levofed, for norepinephrine. I don't get paid by Levofed, I promise. I'm always calling for norepinephrine, but it takes a minute to get that to the bedside. And if I see this, I'm going to intervene quickly. You can't save them all. Sometimes people go down, people lose pulses, and this is where End-Tidal CO2 can really help us. And if we simplify it, it's easy to determine why we have low End-Tidal CO2 early in cardiac arrest. It comes back to these three simple things: metabolism, cardiac output, airway, breathing. I put the End-Tidal CO2 detector on every patient. Early in cardiac arrest, if this is a witnessed arrest, you should get a good End-Tidal reading greater than 20 on everybody. Early in cardiac arrest, on almost everybody, you should get good End-Tidal CO2 readings. They did a study, really cool. They took cadavers that had been dead for greater than 24 hours and they intubated them and hooked them up to End-Tidal CO2 and started bagging them. And everybody had a really good End-Tidal CO2 tracing. They had CO2s in the 40s, 50s, some even higher, because that CO2 was still hanging out in their lungs. Now, there was no cardiac output. There was no metabolism going on. So after a few breaths that quickly dropped, everybody early in arrest, you should be able to get the End-Tidal CO2 greater than 20. If you can't, it's one of these three things. Forget everything I said. You don't have to listen anymore. This is the only point I want you to take away from this lecture. If you weren't paying attention, if you're on your phone, I get it. It's late. I'm kind of boring. Pay attention right now. Low End-Tidal CO2 early in cardiac arrest is a chest compression issue. It's a chest compression issue. And it is a chest compression issue until you're absolutely 100% sure it is not a chest compression issue. I like mechanical compression devices. I like, the different devices, the robot that's going to do chest compressions for me when combined with End-Tidal CO2. If I have the robot on and my End-Tidal CO2 is greater than 20, let's ride. I've just freed up a person. If I have the robot doing my chest compressions, I'm early in the arrest and my End-Tidal CO2 is 7, 8, I'm popping it off. We're starting manual compression. I'm locating the heart with the ultrasound, make sure we're actually compressing it. I may switch out compressors, make sure we have an appropriate rate, make sure we have appropriate depth. We're going to talk about a lot of other cool stuff End-Tidal CO2 can tell you. This is your takeaway for all of my talks. Low End-Tidal CO2 early in cardiac arrest is a chest compression issue. Fix your chest compression. The second thing you need to think about is your tube. How am I getting this gas back? You know what? I changed out manual chest compressions. I located the heart. We're actually compressing the heart, squeezing with the heart with each beat. Then check your tube. Check your tracing. Am I seeing a tracing like this? Something that looks more esophageal? Is that tube slipped into the esophagus and that's why I've arrested? If you have an LMA, it may not be seated properly. You may need to try to reseat it or just extubate and do a BVM. If you want to do End-Tidal CO2 with your BVM, you actually connect it to the mask in between the mask and the bag. The key to that, though, is you have to hold the tight seal through exhalation. But if I see this, it is an airway issue. And the easiest way to rectify that is just BVM. BVM, give breath. I got really good chest compressions. I've confirmed. I peaked with I've got a good boxy tracheal waveform. My tube is in the trachea. And we've been down for 3 minutes and my End-Tidal CO2 is 10. What else could be going on? Well, you could have a brick wall in between these two guys. For some reason, carbon dioxide can't get from the heart to the lungs. What can get in between the heart and lungs and prevent carbon dioxide? Y'all can yell it out. It's fine. PE, my God, thank you so much. You can have a giant pulmonary embolism that's preventing preventing blood from getting to the heart into the lungs, right? And if blood can't get there, carbon dioxide can't get there. Really, any form of obstructive shock. If you have tamponade, it's the right ventricle that gets knocked out. If you have a tension pneumothorax and things get twisted, it's the right ventricle that gets knocked out. If you are sure we're doing good chest compression, if you're sure my tube is in the right spot, think about obstructive shock. Get your echo probe, look for your tamponade. Early in arrest, I still look for dilated right ventricle if I'm early in arrest. And then think about a pneumothorax. Scan laterally on the chest looking for a pneumothorax. That will get you through most of the instances early in cardiac arrest. The last point that I'll make is if you were late in cardiac arrest, your End-Tidal started out great. We were rocking at 30. We're going. We went to 20. We went to 10. After 20 minutes of cardiac arrest, this is a metabolism issue. If I've been going for 20 minutes, if they've been doing pre-hospital interventions for 20 minutes, and now my End-Tidal CO2 is less than 10, metabolism of my body is shutting down. Tissue is dying, means my heart is dying, my brain is dying. At this point, after 20 minutes, you can use this for prognostication, but please don't fall into the trap. early in arrest trying to use this for prognostication. Guys, thank you so much for your time and attention. I really enjoyed it.